Hi, everyone. Welcome to our webinar. We're going to allow a few minutes for people to arrive and also start sharing information about interpretation.
Hola, bienvenidos a todos. Vamos a dar unos minutos antes de comenzar para que se unan todos los que se registraron y comenzaremos en unos minutos. También les vamos a proporcionar información sobre cómo acceder a la interpretación una vez que comiencen las presentaciones en inglés.
Welcome, everyone. Thank you for joining us tonight. We're allowing a few moments for others to join us, and we also have announcements about interpretation and also in the chat.
Bienvenidos a todos. Estamos esperando unos minutos a que lleguen más personas que se han registrado y vamos a dar unos anuncios sobre accesibilidad e interpretación a español. Unos momentos.
So, hello, I'm going to say this message in English and then I'll repeat it in Spanish. The organizers of today's event believe in language justice, and that includes interpretation in Spanish, as well as ASL interpretation and closed captions. Los organizadores del evento de hoy creen en la justicia del lenguaje y eso incluye interpretación en español, incluye interpretación a través del lenguaje de señas y también incluye los subtítulos o capciones en la programación de hoy. To access the interpretation, if you're joining from a computer, you can follow along via the image that you see on your screen right now. You can click the globe that you see in the bottom right hand of your screen, click the language in which you would like to participate in, and you can also choose to silence the original audio, so you can just listen to the interpretation. Si se están uniendo a través de una computadora, para poder unirse a la interpretación, lo que van a hacer es buscar un globo terráqueo que está al fondo de la pantalla y luego seleccionar el lenguaje en cual les gustaría escuchar y participar hoy. If you're joining from a smartphone or a tablet, what you can do is look for 3 little dots that are in the corner of your device. Click those 3 little dots and then click where it says language interpretation and then select the language in which you would like to participate in. And remember to hit done. Si se están uniendo a través de un celular, lo que pueden hacer para poder acceder a la interpretación es buscar 3 puntitos que están en una esquina por ahí de su celular y luego seleccionar donde dice interpretación de idiomas y luego seleccionar el lenguaje en cual les gustaría escuchar y participar hoy. Y recuérdense que pueden silenciar el audio original. No sufren en silencio, don't suffer in silence. If you have any questions, please reach out to the hosts or myself and we can make sure to help you. Si tienen alguna pregunta, nomás comuníquense con los anfitriones de hoy o con yo o con alguna de las otras personas de hoy y podemos ayudarle. And with that, I'll pass the mic back.
Thank you so much. Welcome, everybody. We're really glad that you're here today. My name is JD Davids. I am a light-skinned white person with short hair, and I'm wearing a dark gray pullover sweater. And in the corner of my screen is the logo for Long COVID Justice, which is capital Black letters on a white background inside of a Black circle. I'm a health justice strategist dedicated to national networks of disabled and chronically ill people. And I founded Strategies for High Impact and its national network for Long COVID Justice in 2021. So I'm introducing you to the webinar today and doing my own introduction. I've organized and worked with many pivotal groups, including ACT UP Philadelphia, Coalition for a National HIV/AIDS Strategy, Health Gap, Health Not Prisons Collective, HIV Prevention Justice Alliance, Positive Women's Network USA, and the US Caucus of People Living with HIV, and served as an external expert advisor to the NIH, CDC, and local health departments. As a queer and trans person living with myalgic encephalomyelitis, or ME, long COVID, and other complex chronic conditions, I write and host conversations for the Cranky Queer Guide to Chronic Illness. I sit on the board of ME Action, and I'm a contributing member of the Patient-Led Research Collaborative. And I'm delighted to introduce my partner in justice as Strategies for High Impact, Gabriel San Emeterio. Gabriel is, who uses she, they, or her pronoun, or he pronouns, is a queer activist from Mexico City who migrated to New York City 22 years ago. They hold a master's degree in social work with community organizing as a method of practice and a certificate in social policy. Gabriel's life experience as a person living with HIV, ME, and other complex chronic conditions fuels their passion for disability justice and liberatory community work. So I'm going to turn it over to Gabriel. Thank you.
Thank you, JD, and thank you everybody who is here today. Let me remind you that this webinar is going to be recorded. However, none of the attendants will be in the recording, only the presenters will be in the recording. The recording and the transcripts will be released later, so if you cannot stay with us for the duration of the program, you can check them out later. We'll send an email, a follow-up email after today. You don't have to worry about taking in all that information that's on your screen. It will be sent to you also in a follow-up email. Additionally, I do apologize if my if you see me searching for words. I live with myalgic encephalomyelitis, and one of the ways it affects me is cognitively. We have ASL interpreters today, and they will be on the side of your screen. They'll be highlighted. And if you click on their square, there's 3 little dots on the upper right corner. You can pin them so that when slides are shared and the ratio of the screen changes, they don't turn into small little squares. The chat has been disabled for accessibility reasons. That is so that screen readers don't pick up what's happening on the chat. So all of your questions, please direct them to us via the Q&A that is at the very bottom in the options right next between live transcript and raise hand. If our tech could figure out how to drop the link for accessing the closed captioning link in the Q&A, otherwise we might have to open the chat to everybody so that they can see the link. But there is a link to access the card, the live captioning, and we'll share that with you in a minute. And next is JD, who's going, we want to thank our sponsors today. Our initial co-sponsors. There's the link that should be dropped in the chat, and it's right there. It will be in the chat or in the Q&A if you request it. We're figuring out how to get it to you. And next, we're going to thank our sponsors. These are our initial co-sponsors. We thank them very much for believing in our mission and in this program. AIDS United, Positive Women's Network USA, Broadway Cares, Equity Fights AIDS, and the US Caucus of people living with HIV. Our other co-sponsors are, next slide, ACT UP New York, ACT UP Philadelphia, Black and Latinx Community Control of Health, CNP, Callan Lord, Founders Concerned About AIDS, FCAA, Latino Commission on AIDS, NASTAP, Orasure Technologies, Zero Project, Sister Love, and Trans Latina Coalition. Thank you all for believing in our mission and for your support. And now we go to JD Davids, who's going to provide an introduction to the National Network for Long COVID Justice.
Thank you, Gabriel, and thank you everyone for being here today. I'm disabled and chronically ill, which has been exacerbated by long COVID, but I'm not living with HIV. However, I've had the honor of spending most of my life as an HIV activist, starting with ACT UP Philadelphia 30 plus years ago. So there's no place I'd rather be in community with you as we introduce strategies for high impact and our National Network for Long COVID Justice. In fact, this is our very first event. So please bear with us if we have some bumps along the way. We hope this is but the first of many conversations we'll have together. So let me take a moment to tell you what we're up to. Slides, please. Next slide. Strategies for High Impact is a comprehensive strategic resource built by and building the power of chronically ill and disabled people and the capacity in our groups and networks. Springboard HealthLab, led by the visionary and practical Jen Hecht, without whom tonight's event would not be possible, is an incubator for big ideas that aim to improve health equity across communities. They're incubating this project and co-hosting this program. The National Network for Long COVID Justice is a new advocacy and capacity building network of people living with long COVID, MECFS, HIV/AIDS, and other disabled and chronically ill activists, public health and policy advocates, and intersectional health justice and disability justice groups. Next slide. And here's, oh, thank you. And here's some of the things we're doing with this project in our national network. The national network has a strategy circle of 5 groups that are led by or accountable to people living with long COVID. We're engaging in research advocacy, including seeking changes in the large Recover Initiative, which is an NIH program of research around long COVID. We're engaging in communication strategy and narrative shifting. We're developing fellowships for Black, Brown, and Indigenous leaders with long COVID. We're offering technical assistance, capacity building, organizational coalition development, strategic planning, rapid response, and campaign planning to organizations, networks, health departments, and philanthropy. And we're moving towards hosting the first annual week of interfaith action on long COVID and health justice. Next slide. In our program, Resourcing the HIV Community, which you're here for tonight, we aim to provide affirming, supportive online spaces, increase recognition of the myriad impacts of COVID-19, develop and distribute a report featuring a baseline assessment of HIV community concern, needs, and priorities. And we're establishing linkages between HIV institutions and leaders with emerging networks of people living with HIV, but with emerging networks of people living with long COVID and associated complex chronic conditions. We'll show you the links for our survey later, but if you could take a screenshot or a photo, and we'll also put in the chat, we have a survey in English and in Spanish that we'd love for members of the HIV community to take when you have a chance. Next slide. In this, whether we're working to address the day-to-day needs of our members and communities or fighting in frontline movements for policies and resources our communities need, or navigating the razor's edge between public health and politics in government and civic institutions, our way is not easy. In Strategies for High Impact, we're doing this work by consciously rooting in the teachings and wisdom of our loved ones and movement ancestors, including people who lost their lives in the HIV/AIDS pandemic and those who have died from COVID-19. We dedicate today's session to them. We ask you to join us in a moment of powerful silence to honor them and to remind us of our dedication to ending pandemic harms. Thank you. Next slide, please. For some of us, particularly in Black, Brown, and Indigenous communities, our losses of friends, family, and community members are multiple or unrelenting. We will not allow vested interests or the least affected to push forward to erase our losses, commercialize our grief, or sanitize this crisis for political gain. In the HIV community, we've seen what can happen when we turn our grief into action. Our grief is sacred and powerful. We want to thank our partners in Marked by COVID and their allies who are hosting a series of events for COVID Memorial Day, including a virtual vigil on March 7th. If you'd like to join us there, you can find out more at covidmemorialday.org. Next slide. Those of you who know me know I have a lot to say about HIV, COVID, and long COVID. More time than we have tonight, that's for sure. But my privilege here is to help hold this space for our presenters tonight, and I'll just speak briefly on 2 points before we move on. Now, more than ever, the HIV movement, rooted in our commitment to the meaningful involvement of people with HIV, known as MIPA, originally inspired by the visionary Denver principles, must become intersectional in all ways, including on disability. Being in the HIV community for years, I'd heard people with HIV, living with HIV, say, but we're not disabled, as a call for recognition of worth and humanity. And then in the 2020 film Crip Camp, which was otherwise so inspiring about the disability rights movement, one of the protest leaders says, but we're not sick, on the mic, seeking to do the same thing. We should not have to make appeals for our own humanity by othering anyone else. Oh, I see I've lost our ASL interpreter from the screen, so I'm going to pause.
Yeah, we have Amber spotlighted. Okay, now we have Marquette.
Great. Now more than ever in the HIV movement, rooted in our commitment to the meaningful involvement of people with HIV, known as MIPA, originally inspired by the visionary Denver principles, must become intersectional in all ways, including on disability. Being in the HIV community for years, I've heard people living with HIV say, but we're not disabled, as a call for recognition of worth and humanity. And then in the 2020 film Crip Camp, which was otherwise so inspiring, one of the protest leaders says, but we're not sick, on the mic, seeking to do the same thing. We should not have to make appeals. No one should have to make appeals for their own humanity by othering anyone else. Further, stigmatizing disability means we risk under-recognizing and isolating our own HIV community members, including some aging long-term survivors now dealing with frailty and multiple comorbidities. And now, as we'll hear, people living with HIV are dealing with long COVID. Next slide. The stop, rest, pace slide, if available. Well, I'll just say it verbally. Oh, here it is. Okay. As you'll hear tonight, long COVID can lead to myalgic encephalomyelitis, or ME, something I've had for a long time. If you've had COVID, or even if you don't know if you have, but find yourself fatigued, tiring more quickly, or knocked out right after, or even a day or two after emotional, physical, or mental efforts, that can be post-exertion malaise, or PEM, P-E-M. You can't exercise your way out of it. It could make it much worse or even permanent. So please go to ME Action's resources on stop, rest, and pace. And feel free to reach out to me or Gabriel to talk more about this. Now is my great privilege to introduce two of my dearest comrades. You can take down the slides. Nana Khanna, they, has worked in the HIV field since 2005, following her 2002 HIV diagnosis. She's the co-executive director of Positive Women's Network USA and serves on the board of directors for AIDS United, the steering committee for HIV Racial Justice Now, as the federal policy co-chair for the US People Living with HIV Caucus, as a member of the Women's HIV Research Initiative, and she served on President Obama's Advisory Council on HIV/AIDS. Ronald Johnson serves as the chair of the steering committee of the U.S. People Living with HIV Caucus. Prior to his retirement in 2018, Ronald was vice president for policy and advocacy at AIDS United. He's a long-term HIV survivor and is an older adult living with HIV who uses he, him, his pronouns. So I turn it over to whichever one of you wants to go first.
Thanks, JD. I'll start. Hi, everyone. Again, my name is Ronald Johnson. I use he, him, his pronouns. I am a Black African-American with short gray hair, and I'm wearing a black sweater over a gray shirt. As JD said, I have the privilege of serving as the chair of the U.S. People Living with HIV Caucus. And on behalf of the caucus, I welcome all of you to tonight's webinar, and very pleased to join PWN, AIDS United, Broadway Cares, and the other organizations who are sponsoring tonight's webinar. As we move into the third year of the COVID-19 pandemic, we are learning to live with the persistent reality of an infectious virus. We are learning to manage prevention and to lower risk of exposure and transmission, managing the care of people who experience COVID-19, and comforting the loss of people who have died and whose family members have died as a result of COVID-19. This sounds very familiar to those of us who have experienced HIV over the past 41 years. And it makes the focus of today's webinar timely and very important. Thank you for being here and for participating in this webinar.
And greetings, everyone. I'm Nana Khanna, she or they pronouns. I am a medium brown-skinned South Asian woman wearing spectacles and a red sweatshirt that is kind of like sexy off my shoulder over here. Behind me is a background that says, celebrate and honor Black women in the HIV movement. And along with photo images featuring 20 Black women leaders who are movement ancestors in many ways, some who are still with us and some who are no longer with us, who have paved the way for people living with HIV. So as JD mentioned, I come to this work as a person living with HIV. I also happen to enjoy a lot of privilege and show up on the shoulders of many, many movement ancestors who fought for the rights of people living with HIV and organized to create systems and possibilities for justice in a world where there wasn't any. I want to really thank JD for having us here and for this work. I want to thank Strategies for High Impact for the important work that you all are doing, along with Marked by COVID and many others, to uplift so many of the really important parallels in terms of how our globe and powers that be are responding and are not responding and dealing with the COVID-19 pandemic. You know, in the US alone, there are 1.2 million people living with HIV. And we commonly face a perception that the problem of HIV that needs to be addressed is a problem solely of prevention. And one thing that I think I really want to say to those who are surviving long COVID, and I'm also a survivor of COVID, by the way, is that your voices are so important, and your fight and your struggle and your organizing is so critically important. You know, forces like capitalism, white supremacy, cis heteronormativity, ableism are just some of the forces that are dually structuring the HIV response and the COVID-19 response. But our communities have always cared for each other and have always fought for justice. It is very easy for public health and certain corporate interests to overrun human rights in the service of some idea of what public health really means, as if we ourselves are not also part of the public. And it is critically important, and I think one of the most important lessons of the HIV community, that we remember to always hold those who are most directly impacted and those who are most harmed by intersecting systems of oppression at the very center of our work. That is how we lift everyone up. And I'm just so grateful to be here in community with all of you and looking forward to supporting this work moving forward. Thank you.
Thank you so much, Nana and Ronald, for all you do and for being here with us tonight. We're going to move on to our first panel. It features Dr. Michael Peluso and Hannah Way. Dr. Michael Peluso is Assistant Professor of Medicine in the Division of HIV, Infectious Diseases, and Global Medicine at UCSF. He is an infectious disease physician and a HIV primary care provider at San Francisco General Hospital, who for the last 5 years has focused on chronic sequelae of HIV infection and efforts toward an HIV cure. When the COVID-19 pandemic began, he implemented the UCSF long-term impact of infection with novel coronavirus. That's LINC with 2 I's, pronounced LINC study, one of the first COVID recovery studies in the US. It investigates the clinical and immunologic consequences of the novel coronavirus, including long COVID. He's also a co-investigator on a national study of COVID recovery in people with HIV funded by AMFAR. He also serves as co-investigator in the newly launched NIH Recover Consortium, for which UCSF will serve as one of 15 enrolling institutions nationally. Hannah Way is a long COVID researcher based in Canada and is a person with long COVID. She's currently co-leading the Patient-Led Research Collaborative, PLRC, an interdisciplinary group of long COVID patient researchers and patient advocates at the forefront of long COVID research and patient advocacy. Since April 2020, her team has conducted studies and published papers on long COVID, including characterizing long COVID in an international cohort, 7 months of symptoms and their impact in The Lancet. PLRC's work has been cited widely by the WHO, CDC, in policy briefs and public health guidance for long COVID around the world. She has a background in cognitive science and computer science at Queen's University, Canada. Outside of PLRC, she runs Studio HX, a design and resulted research consultancy, helping teams uncover insights from frontier communities and bridging those insights into impactful products and services. Prior to the pandemic, her work focused on building sustainable digital ecosystems in communities of Southeast Asia and West Africa. And before we begin, I just wanted to point out, we're running about 10 or 15 minutes behind because we're letting things take the time they take. We're going to have a break after Hannah and Michael's presentations, a 5-minute break, and then come back for Q&A. And we welcome everybody back. We're going to be capturing everyone's questions in the Q&A, even if they can't all be answered. And if you have to leave early, or if we run over and you have to leave, we'll be putting out the recording and transcripts of the event as soon as possible, and you'll be able to view them. So now I turn over to Dr. Peluso.
Thanks so much. It's really a pleasure to be here with you today. My name is Michael Peluso. I'm in my 30s. I have light skin and dark hair, and I'm sitting in my office at San Francisco General Hospital, right off of Ward 86, our HIV clinic. I'm going to talk to you today about the connections between HIV, COVID, and long COVID. I'm going to try to talk slowly, but I'm from New York, so I will do my best. So I'm going to begin by talking a little bit about what's known about acute COVID and HIV, specifically whether people with HIV are at risk for more severe manifestations of COVID-19. This slide shows some key issues about the convergence between the SARS-CoV-2, the COVID-19 virus, and HIV epidemics. And this is really nicely reviewed in a paper by Tony Fauci that came out last spring that I'd encourage you all to take a look at. So first, with regard to the risk of acquiring COVID among people with HIV, it seems to be that people with HIV are at similar risk to people who don't have HIV, or even in some cases at lower risk, I think, because especially at the beginning of the pandemic, people with HIV really took the concerns quite seriously. And at least in where I live in San Francisco, kind of hunkered down really early. How about with the risk of severe COVID in people with HIV? Well, early on in the pandemic, we thought that the risk was similar between people with and without HIV if they acquired COVID-19. It turns out that larger, more carefully designed studies have suggested that people with HIV might be at higher risk for severe outcomes if they get COVID-19. And that's probably due to people with HIV having a higher concentration of other medical comorbidities like diabetes, chronic lung disease, heart disease, things like that. And it's especially true for people who have lower T cell counts, particularly if they're less than 200. So I counsel my primary care patients that if they were to get COVID, they'd probably be at higher risk for ending up with more severe symptoms or in the hospital. And then I think it's also really important to acknowledge all of the collateral damage that COVID has done to the healthcare system. A lot of people with HIV have struggled to access care and engage in care in many areas of the country and in many parts of the world. And COVID did not make that any easier. And so that has resulted in less monitoring, more detectable viral loads for people with HIV, and has been a big problem. The next thing I'll briefly address is COVID vaccines and HIV. So are COVID vaccines as effective in people who are living with HIV? And there's pretty limited data on this so far, but there are some concerning studies that suggest that people with HIV may develop a less robust antibody response after COVID vaccination compared to people who don't have HIV. So this is some data from our clinic at San Francisco General. It shows a graph with comparing people with HIV on the right to people without HIV on the left, and looking at levels of neutralizing antibodies. So the ability of antibodies to kind of pick up and tackle and take down the virus in their system after they've been vaccinated against COVID. And what this shows is that there's a higher proportion of people with HIV who don't develop a good antibody response following vaccination. This seems to be particularly true with people who got the Pfizer vaccine. And we think that it's driven by low CD4 T cell counts. So people who have lower T cell counts are less likely to develop a robust neutralizing response. That doesn't necessarily mean that they're more likely to get a COVID infection, because immunity is much more complicated than just antibodies. We don't know so far what's going on with T cells in these people, and they might have protective immunity from T cells, but it's at least one piece of information suggesting that this might be an important difference between people with and without HIV. What does this mean for my patients? I really encourage them to get a booster shot. So this is after 2 doses of vaccine. I've encouraged all of my patients with HIV to get a booster dose. I think there are going to be a lot of studies coming out over the next 6 months, really exploring what these differences could mean for people with HIV. And I think we'll have good evidence on whether or not additional boosters beyond kind of the 3rd dose are necessary going forward for people living with HIV. And for the remainder of my time, I'm going to talk about long COVID and HIV. So are people with HIV at similar or higher risk of long COVID compared to people who are not living with HIV? So this is a story that many of you probably know. In the first few months of the pandemic, many reports emerged really on social media and in the popular press about people who had COVID and then developed persistent symptoms. And this became known as long COVID. awareness of this issue was really driven by organizations and people in organizations like those listed on this slide. And those people, including some of whom are on this call, spent much of 2020 trying to get people to listen to this issue. As a researcher, I heard from lots of participants in my research studies that they felt like they were kind of yelling into the void and their doctors were being dismissive of them. And so most of 2020 was spent trying to get advocacy around these issues. This succeeded in late 2020 when the US Congress allocated over $1 billion to studying long COVID. And now there are massive coordinated efforts in the United States and in many other countries around the world, including in the UK and in Europe, that are specifically focused on trying to understand this issue. And so I'll talk a little bit at the very end about the Recover initiative that JD mentioned. I'm not going to talk.
Take a moment just to switch ASL interpreters.
Sure.
Oh, okay. Here's Marquette, and thank you. Sorry, Dr. Peluso.
No problem. So I know other speakers will go into more detailed descriptions of long COVID, but I'm just going to briefly describe it and then talk about some issues related to HIV. So we all refer to this condition as long COVID, but the official NIH term is post-acute sequelae of COVID, which is abbreviated as PASC. And so many doctors and researchers will use all of these terms sort of interchangeably, but they're all acceptable, technically acceptable. I've shown on this slide some of the things that my patients and my study participants that I work with experience, and you can see that there are a wide variety of symptoms that people can experience. This includes things like neurologic symptoms, headaches, trouble concentrating, fatigue, cardiac symptoms, lung symptoms, gastrointestinal symptoms. Really, I think about this as any symptom that did not exist before a person had COVID and then developed when they had COVID or shortly thereafter and has persisted for a few months. There can be a lot of variability between different people and what they experience, and there can even be variability over time within one person. Symptoms can kind of wax and wane over time. A lot of people who were trying to be sort of dismissive of long COVID early on said, oh, well, this really only occurs in people who are hospitalized, they were super sick, how do you really disentangle that? But the majority of people who have long COVID were not hospitalized with COVID. And importantly, I think that for many people, these symptoms can result in a decreased quality of life, and that really matters. So what causes long COVID? We don't know yet. There are a lot of ideas out there. This slide shows what some of those ideas are. So we know that during acute infection, the COVID virus is really widespread throughout the body. And we know that many people can shed the virus, even if it's not infectious, for a long period of time, weeks, months. And we also know from recent autopsy studies, so people who had COVID and then passed away for some other reason later on, pieces of the virus can still be found in their bodies months later. We think that this can contribute to different things like inflammation in a person's body, inflammation in their specific tissues in their GI tract or their lungs or their brain, issues with clotting, autoimmunity, reactivation of other viruses like the Epstein-Barr virus, for example. And all of these mechanisms can kind of interrelate and probably cause different manifestations of long COVID. So there are huge efforts to try to parse this out now. What about long COVID and HIV? Well, there's pretty limited information, but there are some concerning trends, and I'm actually quite worried about this. So there was a study that didn't get a lot of attention in terms of HIV that came out last year, looking at 1 year follow-up of people who went to the emergency room with COVID in New York. And they found in the study that people with HIV were 1.7 times as likely to have long COVID compared to people who didn't have HIV. The study only had 10 people with HIV, but it was a significant finding. On the bottom of this slide is a study that my group recently posted on medRxiv which compared about 40 people with HIV to 40 people who were well matched without HIV. And we found that people with HIV in our study were 4 times as likely to have long COVID. And this seemed to be related to issues like T cell exhaustion and changes in different levels of inflammation associated with both HIV and long COVID. This is really preliminary data. It's not peer reviewed yet. We can't say definitively that people with HIV are at higher risk for long COVID, but it's a significant finding. And I think that it sort of plants the seed for a lot of better investigation to try to understand whether this is in fact true, because I think it would really matter for my patients with HIV. So in the last minute, I'll just talk about why might this be. There are a lot of reasons why somebody with HIV might be at higher risk for having long COVID. We know that people with HIV can sometimes get sicker during the acute COVID infection. And we know that people with HIV are more likely to have other medical problems. And both of those things are associated with long COVID separate from HIV. We know that people with HIV, even if they're on meds and suppressed, can have higher levels of inflammation that persist despite treatment. And if long COVID is partially an inflammatory problem, you might have the HIV inflammation and then compounded upon that, the COVID inflammation that can make things worse. It could be related to higher immune dysregulation or tissue inflammation in people with HIV. And if it's actually true that reactivation of different viruses like the Epstein-Barr virus are important drivers of long COVID, we know that people with HIV, regardless of COVID, have higher levels of Epstein-Barr and cytomegalovirus reactivation compared to the general population. And so these are all just ideas of why this might be the case, and they're all going to require further investigation. So my advice to people with HIV who are experiencing long COVID is to seek out medical attention and find a doctor who will support you. There are, I hope, more and more doctors who will listen to you and work with you now than there were a year ago. And there are a lot of long COVID clinics that are popping up around the country that I think are going to get better and better at serving the population of people who are experiencing long COVID. I think it's really great for people who are able to participate in clinical trials to do so. And there is a huge need for well-designed clinical trials on long COVID, and there has not been a lot of investment in this yet. And so I think that this is a major area that is in need of advocacy by community activists. And so I hope this is something that we can talk a little bit more about. So in the last second, I'll just talk about 2 studies of long COVID. There's the Recover Initiative. The website is here. This is launching across the entire United States and is going to enroll about 17,000 people who've had COVID, many of whom will have long COVID. It allows self-referrals. And so if you're interested, you should go to the website, and it actually has a map of different study sites that you can engage with. And then this is a study that I'm involved with, sponsored by AMFAR, that is specifically focused on long COVID and HIV. And so it is enrolling people across the US. The entire study can be done remotely. It's phone and Zoom questionnaires and then an at-home blood draw. And so this is enrolling people with and without HIV who get COVID within 4 weeks of having had COVID. And then there's follow-up a few months after that. And so this is active right now, and you can go to this website. And if you know people who are diagnosed with COVID, or if you get diagnosed with COVID going forward, you should definitely reach out to try to enroll. So in conclusion, it seems like certain groups of people with HIV are at higher risk for severe COVID, for less robust COVID vaccine responses, and possibly for long COVID. Long COVID is real. It can be very variable between people, but it's real. Don't let people tell you that it's not. There's no standard evaluation and treatment yet, but there's a lot of work toward this. And there's a lot of really intense investigation that's ongoing. And I hope that a year from now, we'll have a lot more answers. So I'm sorry I went a little bit over time. I'll stop now and then happy to take questions. Thanks so much.
We have Hannah's presentation now, then a small break, and then we're going to have the Q&A.
Hi, everyone. Thank you so much for joining. I want to also thank Michael for that wonderful presentation. My name is Hannah. I am a cis female, also a long COVID patient, also an Chinese Canadian. I am sitting at home in my home office in Ottawa, Canada. And today I want to talk a little bit about contextualizing long COVID in relation to what we found in our data, patient-led research collaborative, and also what this means for the future of long COVID advocacy and also advocacy in general in disability justice. Next slide, please. So the patient-led research collaborative consists of patients who are still sick, long COVID patients, and we were formed in April 2020 in the Body Politics Support Group. We are about 45 people across 3 continents, and we have an interdisciplinary background. We have an IRB from the University College London, and we use that to come up with our own research questions and design our own studies. Next slide, please. At PLRC, we do research a little differently than your standard research process. We involve patients at every step of the process. So patient researchers set research agendas based on what we observe in the community and what we see are priorities that directly serve patients. And from there, we engage in community and ask people to raise questions based on their lived experiences. So one example is vaccine effects in long COVID patients. Then patient researchers and collaborators, we also have external collaborators, conduct analysis, and we publish reports that directly shared back to the community. Next slide, please. We're also involved in both collaborations with academic institutions as well as policymakers. I won't go through the whole list because it's quite exhaustive, but to summarize, we have over 150 citations, including by the WHO, the CDC, and various governments. Next slide, please. I'll take a moment to talk a little more about our most well-received paper. And this is the paper that was published in The Lancet last July. We have over 3,700 patients from 56 countries participating in this study. And we have translated the study into 9 different languages. So it was a massive international community effort. Next slide, please. Some of our key results from the study, which will tie directly into what Michael has talked about, and also what we feel are important for the HIV community, as well as the long COVID community to know, are issues that have to do with testing and also symptoms. So what we found is that when we included everyone who had long COVID symptoms, both who had PCR test results come out negative and positive, we found that not only they have comparable symptom time courses, so similar symptoms over time, but the PCR positive cohort was tested early, on average day 6, while the PCR negative cohort was only able to get tested on average day 43. Now, this alone suggests that many of us simply did not have access to testing. As a result, as you might know, many of us are denied care and disability benefits. And this goes against the narrative that long COVID patients are somehow hypochondriacs. Next slide, please. Looking at all the different symptoms, we organize them into 10 categories. And we often hear most about the pulmonary and cardiovascular symptoms, but some of the less talked about categories include musculoskeletal and reproductive. Next slide, please. We also found 9 categories of neuropsychological symptoms. Again, we hear quite a bit about the loss of taste and smell. And in fact, taste and smell are one of the symptoms when you get triaged for testing. So again, this is creating medical bias. The long COVID patients also suffer from vertigo and memory loss and several others at the onset of COVID. Next slide, please. For long COVID folks who are menstruating, we found that 26% have abnormal periods. Myself and a few other of our PLRC teammates included. And this we have not seen too many studies on. Next slide, please. In our long COVID cohort, we looked at the patterns of recovery, and we sorted these symptoms into 3 clusters. The first cluster looks like an L plotted over time. They are acute symptoms, which we are mostly familiar with, such as sore throat. The second cluster looks like a hill with a long decline on the right. These are symptoms that peak 6 weeks after initial COVID infection. The third and final cluster are what we are the most concerned about as long COVID patients. This one looks like a steep ramp up that plateaus over time. And these are symptoms that are not prevalent during the acute phase, but they stay persistent months after infection. These include tinnitus, joint pain, etc. Next slide, please. We know that these symptoms also come and goes. And not only do they have an impact on the patient's quality of life, but also the ability to make a living. We found that 45% of our research participants required reduced work, and 22% said they were not able to work at all after long COVID. So the rest of the paper can be read online in the link within the slides, and I won't cover them in the interest of time. Next slide, please. But what I want to go over are some of the existing biases in long COVID research.
Just one thing.
Yes.
It seems that something is rubbing against your mic and it's making a noise that it's making it hard for people to hear you.
Oh, 1 second.
Yes, just watch out with your mic. Thank you.
Is this better now?
I think so.
Okay. Sorry about that. So I want to go over how this data shapes the long COVID narrative and how might patients and caregivers be more engaged, as well as the wider disability community. How can we advocate better for long COVID patients and also the wider disability community? Next slide, please. One of the things that we would like folks to recognize, and I mentioned this before, is the testing bias. We need to include not only those who have access to testing, but also probable and suspected cases of infection. So we suggest to use the WHO's definition for probable and suspected cases in cohorts, and this is both for care providers and also for research. We see that only 25% of cases are confirmed to this day, and only 1 to 3% of cases from the first wave, which includes folks who got sick in March and April 2020, were confirmed. And these were predominantly hospitalized patients. And that was a time when we had very little testing. So currently we are missing quite a lot of patients who haven't gotten testing. Next slide, please. So why does discarding those without lab confirmed test result hurt patients other than we're not including that data? What we've seen is that those without lab confirmed testing experience an additional 8 weeks in delay in care. And this is because, when you don't have proof that you have COVID or long COVID, you are denied further care. These people are less likely to have adequate rest or time off. They're more likely to have a loss of income and are more likely to be unable to live alone at 6 weeks. Next slide, please. Won't go over this in too much detail, but antibody testing is also an area that is a bit fuzzy. We see in studies that 36% of patients don't make antibodies, and this has to do with also gender differences. Males are 4 times more likely to retain antibodies, and 36% of female patients lose antibodies between the months of 3 and 6. So this is very relevant to those who have long COVID for that amount of time or more. Next slide, please. Overall, we see that several studies show that long COVID can be predicted by a weak or lacking antibody response. And I know Michael also mentioned this in the HIV cohort. Next slide, please. It's pretty important for us to communicate this to counter current narratives that long COVID patients are mostly hospitalized or have severe cases of initial acute COVID. Even if long COVID happens after 50 to 70% of severe cases and 15 to 30%, and this is verified by various studies, of mild cases, there are significantly more mild cases. So most cases of long COVID actually happened after mild acute illness. Next slide, please. This is something for everyone to keep in mind. We have just a new medical code came out for long COVID, but very few people have been using it. So if you or someone you love, have common diagnoses that are related to long COVID, pay attention. And some of these common diagnoses are dysautonomia, including POTS, ME/CFS, mast cell activation syndrome, small fiber neuropathy, connective tissue disorders, reactivations of other viruses. So it might not show up as long COVID in your medical records, but if you experience these symptoms and you had acute COVID, it might be long COVID. So in conclusion, next slide, please. We want to address some of the issues with long COVID research going forward. And as Michael said, we spent much of 2020 advocating that long COVID exists. And now that we've gotten to the point where people recognize that long COVID is an issue, we want to have more robust studies and more robust treatments that are effective for the people who actually have long COVID. So we need a more comprehensive selection of patients in studies and also in treatment. Most long COVID patients were not hospitalized. Many didn't experience respiratory symptoms onset. Many were not PCR positive or antibody positive. Many had mild acute cases, and many never had low oxygen levels. We also need studies to include issues like post-exertional malaise. So not just look at symptoms at any one given time, but over time. Many studies are missing neurological, especially cognitive issues. And we need studies and treatment options built on post-viral research. Next slide, please. So this concludes my talk. Thank you so much, and thank you, JD, and the rest of the team for having me here. If there are any questions you have regarding our work, I'm happy to answer questions.
Hannah and Michael. Thank you so much, Hannah and Michael. We invite people to type your questions in the Q&A in the chat. We're going to take a little break so the panelists can look at any questions and people can take care of what you'd like to do for 5 minutes. So we're going to come back at 35 minutes after the hour to start back up with a very brief Q&A and then on to our next panel. Thank you so much. We'd like to welcome everybody back. We're going to have the Q&A session has been happening in written form. So I'm going to read out what we have already for relevant questions that have been answered. And just so everyone knows, this recording will be available. It will be posted along with transcripts and links of the presentations and the studies that were cited. So I'm going to read them out and then see if there's any left. Question: can you speak on the recent findings that have come out about T-cell depletion as a possible mechanism behind long COVID and the long-term implications of that? Michael Peluso wrote, great question. There are some studies suggesting that T-cells can be involved in long COVID, but too soon to know exactly what's going on. It's possible that there is a less robust immune response causing long COVID. Also, it is possible there is an over-exuberant response. Question: is there any investigation on long COVID and HIV for the aging? Answer from Dr. Peluso: this is a great question. We've been working with one of our HIV aging specialists in our local study. The AMFAR study I mentioned is looking to enroll older individuals with HIV and COVID as well. And if we enroll enough, we plan on doing a sub-analysis by age. The links to two studies have been posted in the Q&A, the two studies that Dr. Peluso referenced. One is the NIH Recover study, and one is the AMFAR COVID HIV study. And then we have a question that is in Spanish that I will read in English. We have it translated, but first I'm wondering, Gabriel, would you like to read in Spanish with the answer?
The answer, yeah, la respuesta para la pregunta de Rosa, que es de una asociación que se llama Liquidambar. La pregunta es si una persona que no está vacunada y tiene COVID desde el mes de diciembre y no ha buscado ayuda médica a pesar de que tiene los síntomas del COVID-19. No estamos seguros si nos está preguntando o pidiendo consejo médico, pero Hannah recomienda que esta persona busque a un grupo de apoyo de COVID largo en español y vea si hay médicos en su área que puedan puedan atenderla, porque suena como que tiene COVID largo. Y en estos grupos generalmente los pacientes se avisan entre ellos mismos si han avalado o no, o qué trato han recibido de parte de los médicos.
Great,
so the question was about a person who has had COVID symptoms since December. They're not vaccinated and they continue to have symptoms. Hannah suggested that this person seeks a support group for long COVID people and through them seek a medical provider who can take seriously or knows how to deal with long COVID. Generally, these groups have, they vet providers or have recommendations, like peer-to-peer advice.
Thank you. We also have an additional answer from Michael Peluso saying, if someone has persistent COVID symptoms since December, I would really encourage them to be seen by a doctor or nurse to get assessed. It could be long COVID, but it is also important to make sure there is not another problem as well that could be mimicking long COVID. And then we have another question with an answer. I am a person living with HIV and also have had long COVID for over a year now. Are there any ideas about how much longer my recovery will take? And from Michael Peluso says, I wish we had a clear answer for you. Many people will continue to get better over time. You should try to work with your doctor to make sure there isn't another easily fixable problem that's contributing to your symptoms. I hope you feel better over time. We have some additional questions. Hi, thanks JD and everyone working on this initiative. My name is Marcelo Maya. I'm from New York City, he, him, and from ACT UP New York. I've heard many times the word advocacy, and certainly that is excellent, and COVID-19 limitations don't affect advocacy as it affects activism. Yet it was activism which radically changed the course of the HIV epidemic. We must redefine activism for COVID. How do we do that? I think we're going to hold that one for now. A great question. And there's a question about, is there a way to support? Oh, go ahead.
Sorry, the question about advocacy might get answered in the next block. Yeah.
And then we have a question about, is there a Zelle, PayPal, or Cash App to send money to, or where do we recommend that money gets sent? So we can put in the chat where you can make contributions to patient-led research collaborative. And then also we can send out in the notes that we'll send out tomorrow. We'll send information if people would like to support the National Network for Long COVID Justice, how to do that. Okay, so we're going to move on to our next panel, which is going to start with an illustrated journey of long COVID. I turn it over to Pato.
Thanks, JD, and everyone for being here. I'm really grateful to be part of this sacred space with you today. I am a bald, light-skinned, mixed Panamanian wearing a maroon long hauler t-shirt from a Body Politic fundraiser. And of course, Body Politic's one of our partners in today. I'm also a visual artist and a teacher, and I serve as chair of the Department of Art and Public Policy at NYU's Tisch School of the Arts. I'm also an organizer with a long history of working in community-based HIV work. To my struggle and my work with COVID, I bring decades of HIV tools and ways of being that we have built collectively. I thought I would read to you from a few pieces of my COVID writing, and as I read, I'll show you pictures I made with my mobile phone in a large urban park in the center of Los Angeles. I made these images while slowly walking and trying to rebuild my lungs and spirit while recovering. I call this work the Lingering series, and on this title slide, which features the word lingering and my name, Pato Kibert, there is also an image of a silver-looking mask that I will get to later in the presentation. I'll start with reading from my 1-year anniversary of First Symptom social media post, which I wrote almost a year ago on March 2nd, 2021. I'll probably never know when or where I got infected. Beyond my epidemiological geekery, it doesn't really matter. What matters is that the president was being flippant and racist, obsessed with the wrong campaign, the trail of narcissism. And what you see here is a quote from the former president early in the pandemic. It's going to disappear one day. It's like a miracle. It will disappear, rendered in mirrored gold acrylic and his own handwriting. What matters is that public health infrastructure had been eroded for decades and was not properly in place. Profits for some prevailed over health possibilities for all. Resources and mobilization were slow or altogether absent. Intelligence downplayed, science undermined, messages muddled, dereliction of duty rampant. So there it appeared, 1 year ago today, my first symptom in the form of a sore throat. Guidelines didn't even consider it a sign of infection at the time, yet now when I talk for too long or get run down or do a reading or performance like this, the sore throats are still here. They serve as raw reminders, need their remedies, pronounce COVID's claim to the crown of resilience. I'm still here too, with small announcements, not quite my own. Seems strange to mark a 1-year-long relationship with the coronavirus, to make ongoing room for its impact on my body and being. But the Rona and I are hardly alone. Lots of us long haulers are coming up on our 1-year anniversaries of being sick, and scores of the infected aren't even here at all. In the US alone, more than 500,000 people didn't make it. Less euphemistically, they're dead. Of course, that was a year ago, and we're now all too rapidly approaching 1 million deceased from COVID here in the US and many, many more globally. There's barely a day that someone I care about isn't telling me of a person in their life who's died from COVID. Just happened again this morning on a call with an old friend. These dead, our dead, are disproportionately Latinx, Black, Indigenous, elders, working class and poor, papis, primes, tías, abuelas, madres, compas, hermanas, colegas, querides, humanos, ya. It did not have to be this way, does not. I can make my offerings of thanks for being here, and I do, daily, at least as often as I cry, which I do all the time now, thanks to COVID leaving me with a condition called pseudo-bulbar effect. My neurologist explained the condition to me, the diagnosis for all my puddles. She said some people laugh, like the Joker in the Batman movies, and others cry. Like La Llorona, I think, like me. I suppose this COVID symptom is also a syndrome, but I think of the tears as libations, and for me, they come most often in moments of wonder, appreciation, and joy. I can marvel at being able to take a walk and spend time with raptors. I can weep endlessly at your abundant generosity and love that sustain me, the tenderness and care, the unearned privileges of healthcare and flexible work from home, the mystery of a body that is slowly better, if stubbornly not well, a body that does not quit. Yes, I can and should celebrate survival, feel hopeful at the arrival of vaccines, fret over us desperately needing them for more than rich arms and rich nations, hashtag people's vaccine. But in my small and vital celebrations, I'm also minding the mourning and the reckoning to come. Forgive me if this makes me less than merry. Like you, I'm tired and ready for a new world. But La Covia Loca ensures there's no forgetting or repressing. There's no racing ahead, no skipping the line, and there's certainly no going back. There's only the slow and steady making of a more just now. I hope this is the now that endures, an equitable now in which everyone can thrive. I hope this is the glorious hard work that grows and flourishes in time. I hope this new now is one of playful discovery together, as surely as COVID and I have had to learn how to share this body. One long year, COVID, we be in it for the long haul, por vida. So that was from just about a year ago, social media post marking 1 year anniversary. In working with others to try to respond to COVID, two key practices for me are harm reduction, created by communities of people who use drugs and the HIV community, and doula-ing, holding space with and for people in times of transition, holding all the space we need for ourselves while amplifying crip time. An example of this, and another key framework, is Christine Miserandino's spoon theory. We start each day with a finite amount of energy. Getting out of bed or brushing your teeth each use up a valuable amount of your limited energy, or what we call spoons. This has been such a useful reorientation against workaholism and capitalism's notion of productivity for me. I give myself permission and heed many other people's guidance to not overdo it. And here we're looking at a very large ladle entitled Holding Space for Christine Miserandino, who gave us the gift of this framework and practice of minding your spoons. Place helps. Elysian Park in Los Angeles has been instrumental to my healing. It's a vibrant, free, open public space, so crucial to the city and immigrant communities, especially during the pandemic when people need to be together and outside. It's full of many types of trees, including the eucalyptus, which is not indigenous to California. They're only present on Tongva land through settler colonialism. There's a gorgeous giant eucalyptus tree that lost a limb in a 2020 storm. I studied this fallen limb for months and months as I was walking and thinking about spoon theory, relations and cycles of time, geological time, storm time, decolonial time, long hauling time. I couldn't do more vigorous exercise beyond walking. Exertion itself can do harm, for some people living with chronic illness. This picture's by my sister during one of our walks together. I salvaged some of that fallen wood. I've been transforming it into a series of spoons that are also conceptual artworks. This piece is called Variant 1. Here, it appears with Variant 2 and a playful curving spatula that's not quite a spoon. It's titled Flattening the Curve, playing with epi language. The vaccines and the Delta and Omicron variants both created different kinds of COVID time, as does the transformation of this fallen eucalyptus limb. These different scales of time have implication for different forms of care. I feel I am tending to this complicated tree and this place that has tended to me. And this piece is another ladle, this time bowl down. It's called Runneth Over. This is called Flare Up, something I continue to experience quite a lot if I'm not careful to pace myself. This is called Surge. Here, they appear with a piece called Strain, which I damaged while making when I accidentally sanded through the bottom of the spoon's bowl. So I decided to embrace the mistake, as you can see in this close-up, and let the whole grow and find its own life. This piece is called Detail Disoriented, Brain Fog. One of my biggest neurological challenges continues to be difficulty processing information, being organized, following through. I struggle to retain details. And on the left is a spoon titled U09.9, after the classification that, thanks to our activism, the CDC has finally created to help document and better treat those of us living with long COVID. Whenever I go to a clinic, they give me a disposable surgical mask. I've been saving them since becoming ill in March 2020. This is a selfie I took in early April 2020 when I went to urgent care because I was having trouble breathing. I've had these masks electroplated in nickel, an unprecious metal that looks silverish. This one from my pulmonary function lab test on March 12th, 2020. I have 26 of these masks from my COVID visits. The series is called No Silver Linings, Long Calling, and is presented on 3 gallery walls as a timeline of my interacting with the medical establishment. Here, we have some of the most recent, all from just last December, my pre-op, surgery, and SIBO breath test masks. And I'll close with a social media post from January 21st, just about a month ago. Better but not well. Charred, salvaged California live oak and salvaged metal auto parts. So in that same park where I made the lingering images and gathered the eucalyptus limb that had fallen, I also came across this burned out SUV. Have no idea what happened. The aftermath was this scar across the land, and I looked at it for weeks and into months, and then eventually gathered some of the metal parts that had melted in this chaos. Way back in the second month of being sick, April 2020, better but not well became my standard reply to people's loving, concerned, and sometimes incredulous questions about how I'm feeling. I do notice shifts and subtle improvements every 3 months or so, and that's been true over these first 2 years of being sick. Everybody's response, as Doctor reminded us, to this coronavirus is unique, and my symptoms continue to shift and evolve. Pacing and care help greatly, as do mutual aid and community. This piece is called Mutual Aid, and this ongoing series of eucalyptus spoons is the Countermeasures series. Vaccines and boosters are vital. They're only part of the ongoing changes we need. Access to quality, free healthcare, medicine, testing and prevention tools, mental health support and somatic healing, paid sick leave, flexible work schedules and adjusted workflows, safe housing, nutritious food and clean water, vitamins and anti-inflammatory supplements, harm reduction, updated policy and legal frameworks can all make the difference between life and death. So can countering social isolation and ensuring vibrant, safe interconnectedness with one another. This piece is called Hold Me. The work gives a sense of something transformed. I am something and someone transformed. Together, we here at this virtual gathering are a beautiful network of intersecting and fantabulous relations, transforming one another and our shared world. Thank you for holding the changes in me and our evolving we. Gracias. And here we're looking at a collection of spoonies, which I might suggest we are together. Thank you.
Thank you, Pato. Next, we're going to hear a testimony from Philip Shubin about living with HIV and long COVID. The reason why Philip went ahead and pre-recorded his statement, it's because of the unpredictable severity of his symptoms. He is with us and he will be with us for the Q&A. But in the meantime, we're going to present a video where he's wearing glasses with a gray background, and he's wearing also a gray sweater.
Hi, my name is Philip, and I'm a survivor of 2 pandemics, HIV and COVID. I was infected with HIV in 1983. I went on to develop full-blown AIDS 10 years later. Then, in March of 2020, I was infected with COVID. Subsequently, I developed long COVID, and I've been sick for the last 2 years. In both situations, I was infected very early, before there was any conclusive evidence of what was happening and how the viruses were spreading. I'd like to talk about how I see the 2 pandemics intersecting in my life. In 1996, I was hospitalized with pulmonary Kaposi sarcoma, an AIDS-related lung cancer. The care I received in the hospital was so inhumane that I checked myself out against doctor's orders. I went home expecting to die. Fortunately, the triple cocktail of antiviral medication was released at the same time, and it saved my life. But everyone that had had Kaposi sarcoma in their lungs before me died. I was the first in the generation of survivors, but my entire social circle had already died. A friend of mine got COVID and passed away just weeks before the vaccines were released. This loss compounded my already existing trauma. I was tormented once again with the memories of the friends that had died of AIDS before the antiviral drugs were released. In March of 2020, I was infected with COVID. I had already lost my right lung to Kaposi sarcoma. Now my left lung was inflamed and I was gasping for air. At the emergency room, I was once again treated like I had leprosy. I was turned away because there were no beds, and again, I went home expecting to die. In the last 2 years, I have seen dozens of doctors. I have been accepted into the post-COVID programs at both NYU and Mount Sinai. Everyone has been very compassionate, but no one has offered any recommendations for treatment other than physical therapy. And physical therapy may be doing me more harm than good. The doctors don't seem to understand that when I exert myself physically, I suffer from post-exertional malaise. It's as if my battery is suddenly empty and it needs to be recharged, and that recharging could take 48 hours. I've been diagnosed with dysautonomia, a dysfunction of the automatic nervous system. In simple terms, my brain is not sending the proper signals to the organs in my body. The normal in and out of my breathing is irregular. My heart rate is erratic. I have migraines, urine retention, swelling in my feet, pain in my upper back and neck. I am extremely lightheaded and dizzy, often with vertigo. I have tremors and muscle spasms. My sleep is segmented. My digestion is either too fast or too slow. I have been in bed with the curtains drawn for 6 months. I only leave my apartment when absolutely necessary. All of my doctors keep referring to my original case of COVID as mild because I was not put on a ventilator and my original symptoms only lasted 1 week. This terminology needs to change. When someone is sick for 2 years, there is nothing mild about the condition. I don't want to die, but I can't call this living. 2 years ago, I was doing laps around Central Park. Today, I can't walk up a flight of steps without feeling faint. I live between my chair and my bed. When I stand up, I feel as if I'm falling down. The tremors in my hands betray the buttons on my shirt. The food on my fork often does not make it to my mouth. I don't recognize my own signature. The letters seem to be falling down. In addition to dysautonomia, I have been diagnosed with ME/CFS, myalgic encephalitis chronic fatigue syndrome. I'm relieved to have the diagnosis, but frustrated that after 35 years of research, the medical society still knows nearly nothing about the disease. During the AIDS pandemic, I took to the streets with ACT UP to demand funding for AIDS research. I learned that a voice is a powerful tool. It can change the way people think and act. Today, I find myself in a similar position with long COVID and ME/CFS. I am fatigued and lightheaded and dizzy, but I have access to some of the leading medical authorities in the country, and I am compelled to fight for respect, research, and funding every time I meet with my doctors.
Thank you, Philip. That was very powerful. And next, we're going to hear from Lisa Hayim about using and sharing our own strategies, harm reduction and mutual aid. So if we could have Lisa's, oh, there she is.
Hi, my name is Lisa Hayim Carver. I am a brown woman. I use the pronoun she, her, with short brown hair, and I am of North African Arabic descent. My adventures with long COVID, and I can have the next slide, please. This journey started in July 2020 when I got COVID from a situation where I had to give emergency first aid. I did not get very sick at the time, a lot of neurological symptoms, nausea, dizziness, fatigue. But several months later, I ended up in the emergency room with mild myocarditis. And from that point on, developed a lot of the symptoms that you've heard about tonight. And I know many of you are familiar with them. I am not a person who is living with HIV, but I am a cancer survivor. And I have worked in HIV and other public health arenas as an activist for about 35 years. So I still experience since that time a variety of different symptoms. I live in Miami. I have medical insurance, but I have not been able to get good care. I was referred to a post-COVID clinic, but after about 6 or 8 months, the doctor told me that I should be better by now, and that these symptoms on this slide, which I listed that I still have muscle aches, joint pain, nerve pain, headaches, dizziness, difficulty balancing, fatigue, muscle wasting, and brain fog, which feels like shortness of breath for me, that these were probably due to something else, and sent me for a lot of tests. She said, maybe you have cancer again, which I do not. And I was offered a variety of medications, but I am someone who doesn't like to take medicine unless there was really a need for it. And the doctor became impatient with me and told me that there was nothing that could be done, and that this is all new, and they just didn't know what to do, and that basically she could not do anything else. So I am a person who, I work a lot. I work in public health still, and in HIV. I support a lot of different community organizations, especially small grassroots organizations here in South Florida, as well as around the country. And I just felt like I was losing myself. I was losing my grip on just being able to function. And I kind of, I don't know, forced myself to take matters into my own hands. I don't have really a family or anyone that can really provide support. And if I could have the next slide, please. And this is my first time really speaking publicly about this. So I think probably a lot of this information is things that people are already doing, but this is what is helping me function. I'm able to work. First of all, I am someone who worked out almost every day before I got COVID. And that has been a continual struggle because my body won't handle the kind of workouts that I used to do before. They were pretty intense. But what I do find is that it does help me to be physically active when I'm having a flare-up of the symptoms that I described. I will still, if I can, walk for about 30 or 40 minutes, even if it's really slow. I've also found Qigong and Tai Chi to be very helpful to me, even when I'm having a lot of muscle pain or fatigue. If I can manage even 10 or 12 minutes, it really helps me a lot. When I'm not having a flare-up, I've kind of worked to increase the time that I exercise incrementally. Sometimes that backfires, and I do get the post-exertion malaise and other symptoms that other people describe. But when I feel better, I go back to 20 minutes and then 30 minutes. Sometimes I can do longer than that, and I will do yoga, more walking, sometimes step aerobics, weight training, although I haven't been able to go up on my weights to heavy weights like I used to do. 5 pounds is my max. Sometimes I can do 8, and I am trying to build back up and hoping that one day I will be able to. I also, I love sweets, but I have found that I have to really, really watch my sugar intake. I've always eaten kind of a plant-based diet, but one thing I'm learning is that my body responds differently to different foods now. And I'm realizing that sometimes I need to try different things. I now eat fish, maybe once a week, once every couple of weeks, and that does seem to help me with the fatigue. Also, a lot of times I don't have an appetite, but I still try to eat small meals or snacks. Hydration helps immensely, may seem very obvious, but when I'm having a flare-up, I tend to just not be able to do much, and including I don't drink water. I don't hydrate myself because I don't have the energy. So I'm learning that I need to do that no matter how badly I feel. And then the other thing is, for me, is being quiet. That has been a struggle. And I don't mean that in a funny way. As it was mentioned earlier, there are other symptoms besides physical ones that go with long COVID. And one of them for me is really isolation. A lot of my friends didn't understand and still don't, that I just don't always have the energy that I used to talk to them on the phone or in person. And that has resulted in a lot of isolation for me because they've taken it personally, even when I explain why. So it's just something for people to be aware of, that this stuff is real. It's not something that people are making up because we don't want to talk to you. And so being quiet is one of my strategies for managing my symptoms. And when I feel really bad, I will say that a couple of Tylenol sometimes really helps. These are very simple things, but for those of us who are used to being out and on the front lines and being really active and, you know, fighting for what we believe in and what communities need, these are things that is very hard for us to do when we're not used to not having the energy to do what we normally do. So these very basic things have been extremely helpful to me. And if there's one thing on there that you haven't been doing, maybe I gave you a new idea tonight. But I just want to really appreciate everyone else who spoke tonight. I got a lot out of this. And I hope that we can make progress with this fight to overcome what we're experiencing and our communities are experiencing. And I really want to thank everyone who's out there fighting for those of us who have less energy to do that right now. Thank you.
Thank you, Lisa. And on the question of advocacy, you and Philip are great examples. For instance, Philip mentioned that he took to the streets with ACT UP when he was able to do so. But today his advocacy looks very different. However, it's no less powerful. Same with you, Lisa. You are sharing with others your experiences as tools to navigate the complexities that everyday life presents. So for those of us living with complex chronic conditions, every time we advocate for ourselves with a medical or service provider, as difficult as it might be, we're advocating for others as well. And for those of you working in the systems that can make a difference in what we may encounter when we seek out support, care, or resources, every time we advocate to put people above politics and profit, we're opening the doors for others to survive and thrive. We'd like to end with some reflective questions prompted by Pato's journey, and I believe JD also has some things to say in regards to advocacy. Or do we read the prompts first? These are some prompts to send you off reflecting, but go ahead, JD.
Hi, thank you. Thank you so much for everyone who shared your personal journey with everyone tonight. So grateful for you speaking up and what you're doing for yourselves and others. And we wanted to share some action steps that people can take. I'm putting in the chat a link to an open letter that is about the Recover study that has been mentioned several times tonight. This is a massive NIH research endeavor that does not have the kinds of successful patient-led or community-led engagement that has given us such victories in HIV research, and also has distanced post-viral researchers from ME and other conditions who really know about what may be going on with a lot of people with long COVID from leadership of this $1.15 billion initiative. And so we'd love for you to sign on to this letter. Also, we will have a pledge coming out in about a week that is called Pandemics Are Chronic, that seeks to break apart this false binary that there's COVID-19, which is an acute infection, and then people either die or they recover. to a pledge for people to always talk about long COVID in the context of what is the story of COVID, and to also always put that in the context of what has been going on and is needed for the lives of disabled and chronically ill people in other pandemics and outside of pandemics all along. So we'll send that to you all. And then last, we would love for you to take our survey. The survey is a place where we'll be advocating for what people in the HIV community, whether you're living with HIV or service provider or both, or other relationships in the community, to support you in this journey in the third year of the pandemic, this other pandemic. So we invite you to take that survey. We'll put up a link now soon, I think, and then we'll also have it, we'll email it to everyone tomorrow that registered for the event tonight. And we're just gonna put up then back to Gabriel for our closing reflections. Thank you.
Right, we're going to the prompts. This is a send-off. Thank you for sticking around with us as we ran a little bit late for accessibility reasons. The information that's gonna follow the prompts, you do not need to worry about catching it right now. It's a preview of what's to come in the follow-up email, which includes an evaluation and links to our survey. So whenever we're ready with we need the slide with the reflection prompts. There we go, a moment to reflect. As we go off, let's remember Pato spoke about small but vital celebrations. So we invite you to think, what is a small way you can celebrate your work and commitments in this complex time? And two, Pato closed by speaking of our evolving we. Take a moment to consider who is in your evolving we and envision how you support one another. Is there anyone who you wish to welcome into or recognize as part of your we? Is there anyone who you want to make sure knows that you're there for them? We can go to the next slides as we close. Thank you so much for being here with us. Like I said, these following slides are just previews of an email that you will get tomorrow. They'll have all the information. I want to thank our sponsors, thank our panelists and our interpreters, ASL and Spanish, and our captioner. Thank you all for being here and for taking part of this unprecedented webinar. We'll let you know when the recording and the transcripts are available. If anyone has any last words, thank you all very much. Stay tuned.